Okay.
Excellent. Welcome, everybody. Thank you for joining us here in cyberspace to hear about a program that we at RIPIN are very, very proud of. It's a care management program that works with dual eligibles who have both Medicare and Medicaid, which is a population that's very vulnerable and has very high medical needs. And as you'll hear in a minute, one of the things that was very important to us when we launched this program was to engage with a third-party rigorous evaluator. And we're really thankful to the Brown School of Public Health for working with us on this project. And we now have the results of that evaluation, and we're very excited to share them with the community. So thank you and welcome. And Michaela, you can drive the slide forward. So we'll start with introductions. I'm going to pass it to Vicki, Michaela, and David for a minute.
Hi, good afternoon, everyone. My name is Vicki Rodriguez, and I am the Director of Adult Community Care Coordination. I am also a certified community health worker. I've been with RIPIN over 15 years now, helping individuals to navigate many systems of healthcare. Thank you.
Good morning, or technically good afternoon. My name is Michaela Gardner-Higgins. I'm the clinical care manager here at RIPIN. I'm a licensed clinical social worker, been here for almost 4.5 years, providing clinical support to the care management program. And thank you for joining us.
Hi, everybody. My name is David Myers. I'm an assistant professor of health services policy and practice at the Brown University School of Public Health. And I helped to lead the evaluation team for the study, and really excited to share the results that we found.
Thank you, guys. And I am Sam Salganic. I'm the executive director at RIPIN. And just very briefly, since I know we have some people joining from out of state and from all kinds of places, I'll just say that RIPIN is a 32-year-old social service nonprofit in Rhode Island. We were founded by a group of parents of children with special healthcare needs to help families navigate special education. And since then, we've grown quite a bit. We now have 120 staff, and we serve the community, children and families of children with special needs, access to healthcare and health insurance, and healthy aging. But throughout it all, we've stuck to this sort of vision of our founders, which was the model of peer support. So it was founded by parents of children with special needs helping others. And still today, 3/4 of our staff are parents or caregivers to a loved one with a special need, a majority of our board as well. And whenever we create a program, we're hiring staff who have experience from their personal lives that lines up with the community that they'll be supporting in that program. 30 years ago, we didn't call those community health workers, but now we do. It's a trusted member of the community who's helping the community navigate resources. And so today, RIPIN is also the state's largest employer of certified community health workers. And so you'll hear in this program how we've deployed community health workers to work with vulnerable older adults. Go ahead, Kevin. Some of you on this call probably know more about duals than I'll ever know, but not all of you maybe. So just to start from the very basics, this program is targeted towards dual eligibles. And a dual is someone who has both Medicare and Medicaid. So to have Medicare, generally you either have to be 65 or older, or you have to be disabled. And to have Medicaid, you have to have very low income and resources. So this population is at the intersection of both sort of aging or disability and low income and low access to financial resources. This population nationally, not just in Rhode Island, but nationally, has very high healthcare utilization and very high social and economic needs. And as we all know, that's a very difficult intersection. It also drives very poor health outcomes in general. Rhode Island, there are about 37,000 duals in Rhode Island today.
Great. So let me introduce you to Julia, who is one of our original participants to the care management program. When we first met Julia, she was experiencing some challenges with her housing. She was bouncing from her daughter's home, who with also about 4 grandchildren living with them at the time, and her son's home. She was also trying to manage, not successfully, some chronic conditions, which included arthritis, neuropathy, high blood pressure, and diabetes. When we first met Julia, her glucose numbers were truly uncontrollable. They were over 300. She was smoking half a pack of cigarettes a day, and our expert screening disclosed that, and she self-disclosed that she was also drinking heavily every day. So that's a little bit about Julia, and we'll share a little bit more later on.
And Julia did have some options for her coverage, and many, again, as Sam mentioned, many of you do know what a dual is and what sorts of opportunities are there for them to receive their care. One of those options is Neighborhood Integrity, which is a fully integrated Medicare, Medicaid plan. There's roughly 15,000 individuals enrolled, give or take, and Neighborhood Health Plan takes on that risk for their Medicare and Medicaid services. So the individual is fully managed by Neighborhood Health Plan. Another option, which is the population that our program is serving, are individuals who have original Medicare or a Medicare Advantage plan, but they have fee-for-service Medicaid. Roughly about 20,000 individuals fit that mold in Rhode Island, and Medicare covers hospitals, doctors, prescriptions, and things like that. Some of their SNF stays for rehab, but Medicaid covers most of their long-term services and supports. That's within the community as well in skilled nursing facilities. So that does tend to translate into individuals' long-term care. Again, that's state Medicaid that's covering those services. So along comes RIPIN. We were created through the fiscal year 2019 budget as the Unity program from Neighborhood Sunset. So all of those individuals who were being covered by Neighborhood needed some support. They were transitioning to that original Medicare, Medicare Advantage, and fee-for-service model. So a few stats here around where our program actually came from, and that our primary goal is meant to really focus on reducing that long-term skilled nursing facility stay, because that is where the state can continue to see the most savings. There is a heavy weight on nursing home costs currently. As you can see here, there's a big difference between the cost that state spending on home and community-based services versus the nursing home care. So there's a big opportunity to really look at why folks are going to the long-term care facilities and provide them some support in the communities so that they can access those services and again, increase some savings. Duals are very likely to have long-term stays compared to their Medicare-only comrades. There's the Medicare-only versus a dual eligible has really no difference in their makeup, their needs, but they're so much more likely to have a long-term stay. And again, for our population, we're focusing on folks who are costing the state on the Medicaid side to experience those long-term stays. Our program is set up by the community, driven by the community health worker, as Sam mentioned. We really function on a peer model. So our community health worker is helping be that bridge to our clients, and that's off by trying to learn about what they need, where are they in their care journeys, what's really important to them. In addition to that community health worker, our clients have access to clinical team members, social workers, nurse case managers that are available to the client, but also there to support the community health worker doing their best work. We have a housing specialist who's able to help address some of our individuals' housing needs and help them navigate that challenging system. And we are a very high touch program. So our staff are able to go out and see our clients very frequently, meet them where they're at in the community, and really try to be that immediate support for anything they might need. They're out there doing home visits, and they're helping them navigate that Medicaid space, those community-based long-term services and supports that can really make a big difference in their situations at home. It's a lot of accessing home care, durable medical equipment, and looking at those other social determinants of health. So food, housing, utilities, and things like that, that can, again, make a really big difference in their situations. Pass it over to David.
Great. So thank you. So we were brought in from the Brown University School of Public Health to do an evaluation of this care management program. And the goal of the evaluation was to try and understand what the impact of this intervention was on different types of utilization, with a focus on SNF stays, SNF utilization, hospitalization, as well as preventable ED use and as well as total Medicaid spending. So to do this, we had a terrific team from Brown that was originally led by Anya Wallach, and I took over later on in the project. And I also wanted to call out one of our terrific PhD candidates, Emma Tucher, who led a lot of the analysis for this work. And so our primary source of data that we used to conduct our evaluation was the Rhode Island All-Payer Claims Database. And for those of you who aren't familiar with it, the Rhode Island APCD combines together claims data from all of the different insurance sources in the state of Rhode Island. So that includes both commercial insurance as well as the Medicare and the Medicaid program, which enables us to be able to follow people throughout the year to see what types of utilization they're getting, what type of spending is associated with this utilization, and if there's a change over time after they receive some type of intervention. We can go to the next slide. So in order to conduct this work, we used the Rhode Island APCD, and we worked with RIPIN and the APCD to identify beneficiaries who were exposed and who participated in this care management program. And we specifically looked at those who were screened by RIPIN to have the needs that sort of required active care management. So people who actually received this intervention from RIPIN. Our sample for this initial evaluation included about 170 participants, and we identified them using sort of matched enrollment records. So we're able to track these individuals and see what type of utilization they're using over time. Our primary study design for this evaluation was what's called an interrupted time series, which basically allows us to follow somebody's care use patterns up until they start to receive an intervention. In this case, they were sort of brought into the care management program. And then we follow them after they're exposed to the care management program to see if there are any differences in their utilization and any differences in their outcomes that we can then sort of attribute to the program. Our pre-treatment periods took place between 2017 and 2018, and our post-period was in 2019 and a lot of 2020. And we adjusted our analysis using different control variables, things like age, different chronic conditions, in order to try and make sure that we were reflective of sort of the general population. In addition to the quantitative methods, we also led a number of qualitative interviews with RIPIN staff, EOHHS staff, as well as participants of the care management program and the community health workers themselves to get more of a sense of how this program was looking on the ground, because the numbers can provide you some of the picture, but they can't provide you all of the picture on the quantitative side. We can go to the next slide. So the first thing that really stood out to us is that the participants who were in the RIPIN program were very sick. They had substantial chronic disease burdens and actually had much higher chronic disease burdens than we saw a lot of elsewhere through the state among sort of Medicare beneficiaries alone or among Medicaid beneficiaries alone. You can see here that about 90% of the participants had hypertension, about 60% had diabetes, at least half had depression, and most beneficiaries didn't just have one of these conditions, but had multiple of them or even all of them. And so it's a very sort of high need group of individuals who participate in the program, which is important to keep in mind as we think about these outcomes. We can go to the next slide. Going through this, first, as I said, we found that the RIPIN participants tended to have higher rates of comorbidity than a lot of other people sort of throughout the state of Rhode Island. Next. We found that participation in the RIPIN program was associated with fewer hospitalizations. And so we found that participation in the care management program reduced about over 100 hospitalizations per member quarter or per 1,000 member quarter. So quite a few people were potentially avoided the hospital as a result of this intervention. Next, we also found significant reductions in SNF admissions and shorter SNF stays. We found that there were about 70 fewer SNF admissions per 1,000 person quarters and about 40 fewer stays of 20 or more days per 1,000 member quarters. And last, we also found that the program did seem to be associated with significant reduction in Medicaid costs, likely due to these sort of lower hospitalization and lower SNF rates that we saw. And it was about a $7,000 per member per year reduction in Medicaid spending that we could attribute to participation in this program. Next slide. So this just shows sort of the same results again. So we also did look at ED visits, and while we did find reductions there, they weren't statistically significant, which may have been sort of a power related issue. And we did also see downward trends in Medicare spending as well, but that also wasn't significant. So overall, we did find that participation in the RIPIN program did seem to be linked to sort of lower uses of these utilization that can be incredibly costly and also incredibly disruptive in sort of people's day-to-day lives. And I'll hand it off from there.
Thanks, David. As David had mentioned, we had sort of this qualitative piece to this evaluation, and one of our favorite things is to get feedback from our clients. So they're the ones that are experiencing their healthcare needs as well as our program. And we got some wonderful feedback around the type of support that our clients feel as though they're receiving. You know, they talk a lot about getting my independence back, being able to manage their needs at home, and just really creating or seemingly creating a pathway to really getting exactly what they need so that they can live out their lives in the community. A lot of talk around bridging communications between all of the different agencies and departments where folks really need to know how to access in order to get the types of things that they need. Another piece that we're very proud of here is the, our slide's not cooperating, but 98% of our participants surveyed feel respected by their care coordinator. So that peer piece is really important. Our care coordinators are able to really establish a great working relationship with their clients and really help learn around exactly what they're looking for in order to get the best health outcomes. So hand it back to Vicki.
Thank you, Michaela. So to bring it back to Julia, after she engaged with our care coordinator and a health risk assessment was conducted, we were able to help her put a plan in place, which included many things. So one of the first things that our care coordinator was able to do for Julia was to get her a glucose meter, which helped her to manage her diabetes on a daily basis. The other thing that she was able to do was to help Julia's care partner, which was her daughter at the time, secure childcare, which then helped to reduce some of those stressors within the household. that Julia was a part of. Julia agreed after some education from our nurse case manager to participate in a smoking cessation program. At first, she was a little hesitant to participate in the program to reduce her drinking, but then decided to put a network in place to be able to do that. So those are a few of the things. She received education on eating habits and all around things to help her manage her health. One of the things that you can see here in this photo that was very important to Julia, who didn't have a place to call her own for quite some time, was that she ended up being able to secure an apartment for herself. And that opened the door to many other things for her. Her social life improved, her overall well-being improved with all those things that were put into place. And one of the things that Michaela touched on was that relationship with the care coordinator. That was an important factor in this success as well, Julia's success. Sam?
Thank you, Vicky, Michaela, and David. So, this program was really built on a theory or a conjecture that taking some of our highest risk, highest need dual eligibles in the community and connecting them with a supportive peer, a community health worker who could help them navigate the benefits and services available to them, would help them be healthy and independent in the community for longer. And we built out the program, and it was very important to us that we test that theory. And this is the first way that we've done that is through this evaluation. And I think the initial results are very, very promising. And we're really proud of the work that everybody in this program has done, from senior leadership, Vicky and Michaela, all the way down, all the way across to the community health workers who are out in the community every day. Now, the nature of evaluating healthcare interventions is that it takes a long time. You may have noticed that our study period ended, in 2020. That's when data become available. So a lot has actually happened since this evaluation. When we ran this evaluation, I think our treatment group was 169 patients. That was sort of the first cohort who were assigned to us. We have since scaled the program significantly. We now serve about 600, a panel of about 600 individuals at any time. And we've used care management dashboards to help us target and outreach to patients who have recently used the emergency department frequently or had multiple recent inpatient admissions. And we can reach out to them and ask if they need our support. And that's the way that we've grown the program, not only hopefully doing really high quality community health work, but doing it with the right patients who are at high risk or rising risk. One thing that we hope to do next is to build a random control trial. We have actually scaled the program in a way that we think makes it amenable to that. And that's something that we're hoping to do in the future if we can identify funding. The next slide just shows the citation to the program evaluation, which is now published. So congratulations to Emma and David. And we will send that out with the materials after the webinar. I see a couple questions. I'll start to answer a couple of them now, and then maybe we can take a few more because we have some time. So the first easy question is, will the PowerPoint be available after the talk? Absolutely. We're going to send it out with the post-webinar materials. There's a question about the cost of delivering the intervention as compared to the savings. So that's a great question, and I'll make 2 points. First, it depends on when you measure, because we've scaled the program significantly since we started. If you look at the program today, we are delivering the program at a savings where you could take our added cost and it would be less than the savings. David will be quick to tell you that that was one slice of time and one study, and it doesn't necessarily mean that in all circumstances forever and forever that each individual we serve will generate that exact amount of average savings. And the second point I'll make about the cost, and care management programs live in a kind of an interesting space because yes, we're out there. State governments, insurance companies are interested in funding these activities, partly out of a motivation to save in healthcare spending. I think we also have to remember the other side of why we're doing what we're doing, and the vast majority of older adults, the vast majority of their families, they prefer to age at home. People generally, now, of course, skilled nursing facilities absolutely have a place in our continuum of care, but if you ask patients where they want to be and where they want to age, most say they want to age at home. And so programs that help people do that, I think, have a value, even if they don't save money. And this one does save money. So I don't know, Sarah, if you want to maybe MC some, if people.
Sure. So if you have questions and you want to ask, you can raise your hand and I can unmute you, or you can pop them into the Q&A.
I see a third question there. Did we calculate the savings to Medicare? We did, and you can see the results in the published paper, and it was on that slide. It showed a reduction in Medicare spending, but not statistically significant. Is that correct, David?
Yes, yeah, that's correct. So we did not see increased costs. It looked like the Medicare costs were trending downwards, but we didn't have statistical significance for that. And some of that is this is a relatively small study. We had 170 participants to look at so far. And so we're really excited about potential opportunities to sort of scale up this evaluation work. And I also just want to sort of echo Sam's comments before about, putting these savings in the context of the larger, outcomes of the intervention. That from the qualitative interviews, it was clear that there were large quality of life improvements that people were having from this program. And so the cost savings is only one piece of it. And there's keeping people out of the hospital and keeping people at home is sort of an important endpoint outcome in and of itself.
There's another question. Who is the typical person who is a care coordinator? Do they receive significant training by your organization?
I'll pass that to Vicky or Michaela.
Sure, we can tag team that, Michaela. So yes, the typical care coordinator is an individual who has navigated the systems, has lived experience caring for a loved one, or has experienced some of these systems themselves personally. So they bring that shared perspective, and which helps them to quickly earn the trust of the participants. So that's one of the key things. We receive all of our community health workers are certified through the Rhode Island Board of Certification. So RIPIN provides intense training for a period upon hire. As soon as they're hired onto RIPIN, for about 15-18 months, they are set on track to become certified if they're not already certified. And through internal programs and external opportunities, we continue to provide them with trainings so that they can continue to be certified. Every 2 years, they'll be recertified. So I hope that explains a little bit as to who our CHWs are. Michaela, if you'd like to share a little more.
Sure. As Vicki mentioned, there's a lot of lived experience amongst our staff, and it's the same with our clinical staff as well. Our social workers and our nurse case managers all have navigated these spaces on behalf of themselves or family members. And they, particularly our community health workers, are members of the same communities that a lot of our clients are members of. So they know every rock and every bush to look under for those exact resources that may not be Medicaid funded, but they're going to help get that individual the help that they really, really need. So they are, and I look at the question, it says, who is the typical person? It's all of us, think about when you've had to navigate a really challenging healthcare decision. And so have our clients, and they're able to walk with rather than in front or behind our clients, which is a really special thing.
Hey, thank you, Michaela and Vicki. The next question is, what strategies did you use to recruit participants for this study?
I'll take that one. And it kind of leads into the following question too. So for this study, this was actually all of the participants who we were working with in our initial cohort for the care management program. And they were identified as part of the wind down of a the neighborhood unity program, which was a managed care program that was a managed LTSS managed care program. They had a population that was in their care management who had been identified by them as higher rising risk. And as that program was wound down, they passed their care management caseload to us. I hope that answers the question. And what care management dashboard do we utilize? We use the Rhode Island Quality Institute's current care care management system. We use both the dashboards and the alerts that tell us about admissions, discharges, and transfers.
I also just want to add to Sam's comment about who was included in this study, because we did also look for folks who were really receiving, making sure that they were clients who had care plans with us, who were working on goals, who were actually, experiencing the program, which a vast majority of them are. So just wanted to point out that they were people who were really receiving the supports of our entire bench. So a community health worker, a nurse case manager, or a social worker. So they were really getting the true CMP experience.
Great. Okay. So there are no other questions in the queue, but again, feel free to pop some in there or raise your hand if you want to speak. Okay. Laura is asking, most people do want to age at home, but many cannot find enough help to stay at home due to lack of CNAs and home health aides to be able to stay at home safely. What did the study find out about lack of staffing in the community?
I'll just say that this study wasn't focused on that, but I'll pass it to maybe Michaela to reflect on the experience that's one of the core things that our community health workers are doing sort of all day, every day with these clients, is helping them access these benefits. So Michaela, what are our community health workers hearing and feeling?
Yes, so they certainly experience that on a day-to-day basis and really, understand clients and can empathize with clients when they're coming to them saying, I've gone X amount of days, X amount of months, sometimes without any home care supports. So to Sam's point, that is a really big piece of what the community health worker is trying to help address. Again, not necessarily from a systems perspective of the lack of supports, but they're trying to meet that individual's needs in any way that they can. Sometimes that means an extra phone call here and there to make sure everything's going okay, talking through that individual's natural supports. What do you have? Who's around you that might be able to help provide you support? And trying to build a system around that, or help repair some of those relationships, or just really think through and looking at it from a bird's eye view to try to find those resources that are going to make a big difference and at least provide some sort of safety net to the individual. We talked about the durable medical equipment. We talked about, the housing and some of those pieces that aren't necessarily care related, but absolutely translate into an individual's safety and well-being at home. But it is certainly a challenge, and our staff work very hard to try to find those services, but also help communications when there might be services in place, but the client is questioning whether or not it's a right match for them. But our community health workers are already having conversations and trying to help support that relationship and manage that relationship with any existing home care as well. So as not to lose it. Vicki, did you have anything else to add there?
No, I think you covered it, Michaela. Thank you.
Okay. Not seeing any hands raised or any other questions at the moment.
I'll close out by thanking all of you for spending some time with us this afternoon. And I saw the registration list, so I also want to thank all you for all of the great work that you're doing in the community as well. And if you ever want to learn more about this program or connect with us, just reach out to any of us. Our contact information is on the first slide, and that will be distributed soon. So thank you all.